All right. So, like I said, my name is Olutayo, and I am founder of the Do Influence, which is an educational platform that hopes to educate, empower, and influence students of all ages. Really, a place where students can network and learn more about different careers and professions, and really just help them achieve their career goals and aspirations. So, with that said, I would love to go ahead and introduce our panelists. Uh, this little screen that you have, the slide that you have on your screen just sets our ground rules. So please make sure that your phones are on mute. Make sure that you can see us on your speaker view, and just be ready and excited to participate. We're going to basically have the ability to have an open question and answer session at the end, and we would love for you to participate with us. So our panelists for today are Dr. Matura Harmon. Dr. Harmon is a board certified obstetrician and gynecologist who practices just outside of Houston, Texas. She is very thrilled to be here this evening and loves to participate in women's health and health prevention and education. So why don't we have a wave from Dr. Harmon? Awesome. Next is Dr. Kristen Collins. Dr. Collins is a board certified general surgeon and breast surgical oncologist. Dr. Collins is also very excited to be here with us today, and we are excited to have her. She will be able to answer all your questions about breast health, prevention, treatment, and everything in between. Dr. Collins, can you wait for us today? Awesome. And Dr. Valerie Akawande is our Doctor of Physical Therapy extraordinaire. She is well versed and also thrilled to talk to us about pelvic health and women's health. Dr. Akawande has additional training in pelvic health and pelvic physiology that she'll discuss with us today, and we are extremely thrilled to have her with us this evening. Can you wait for us, Dr. Akawande? Awesome. And you'll also see on your screen Miss Alicia Garnett. Miss Alicia Garnett is our education coordinator for the Do Influence and really helps us get these webinars together. And it's just a thrill to work with her and have her with us today. Can you wait for us, Alicia, again? Awesome. Okay. So we're going to go ahead and get started. And like I said, my name is Olutayo Sagunro, and I will be your moderator. So let's get started. Let's start talking about some gynecological health and preventative care with Dr. Harmon.
Hello, everyone. Again, I'm Dr. Harmon. Thank you for the introduction, Olutayo. I'm happy that all of you guys are here. I just want to start off with the topic of preventative care. So, as a gynecologist, I am basically your first line of defense in terms of prevention for gynecological cancers. And so we act for many women as their primary care provider, but our focus is really on women's health and prevention against gynecological cancer. So although we can manage hypertension, diabetes, thyroid disease, etc., our primary focus is to take care of just the women aspect of things. So whenever you come for your primary care visit or your wellness visit, I should say, it's the dreaded examination. No one likes the pelvic exam, but when you come into our visit, we want to get a thorough history and physical, and this is an opportunity for you to be able to ask the questions that you've been thinking about, that you couldn't really talk to your friends about, or you Google searched it and you now think you have some type of cancer or something. And so we give you the opportunity to ask us about any abnormal bleeding, any urinary dysfunctions, this discharge that you have, your libido is low, questions about fertility or infertility. And so, we want to be able to ask those questions, address those questions, and then do a thorough physical examination. And so here it lists the Pap smear. And so we encourage our patients to come annually once a year, but the Pap smear guidelines really spaces them out to every 3 to 5 years, depending if we're doing HPV testing or not. So we want to do a clinical breast examination, and this allows us to screen for any masses, pain, or breast symptoms that you may have. With the pelvic exam, we are able to screen for cervical cancer. We're also able to screen for ovarian cancer. There's no special test for that like the Pap smear, but we're able to feel the ovaries, feel the pelvic anatomy, and make sure that we're not feeling any growths or masses or firmness in the pelvis. We also, with the preventative examination, do lab testing. And so that allows us to screen for diabetes and thyroid disease, where at that point we can manage it. Some gynecologists don't feel comfortable managing that and would prefer to refer to a primary care doctor, like a family medicine or internal medicine practitioner. Another thing that we really focus on during your wellness exams is STI or STD testing. So STI is sexually transmitted infection testing. And the importance of that is because there surprisingly are a lot of women that have gonorrhea or chlamydia or trichomonas and are asymptomatic. And in our management of preventative care, these infections can lead to infertility. So routine screening for these infections is important to preserve your fertility and also to curb the spread of disease. So basically, the preventative exam starts at around the age of 21 as well as Pap smears, but we do encourage patients to come in as young as 13 or even younger if you're sexually active. And that gives us an opportunity to really educate young women about their, gynecological health, safe sex practices. We encourage contraception. We want to talk about that and educate people that it's not just about birth control. There's many other reasons that we use birth control pills for regulating your menstrual cycle, for acne, for just hormonal changes that may be going on in the adolescent, some for PMS symptoms. And so, I think that if you are someone that doesn't come to your gynecologist regularly, we would encourage you to do so, even though, we can space your Pap smears out to every 3 to 5 years. So it is recommended that you come annually. As an OBGYN, as I mentioned before, we're your first line of defense, but we do kind of share in the care team in terms of referrals. So if we do find a problem that we're concerned about that we can't really manage well, then we often will make referrals to other specialists. And so, coming into your gynecologist, we want you to feel safe and comfortable. And there's a lot of things that people tell their gynecologist that they're not comfortable with telling their other providers. And we want you to feel comfortable and not dread coming to the visits because of the pelvic exam and the speculum that, nobody loves those exams. But we do encourage you to come annually. I think that's my segment.
Excellent. Thank you so much, Dr. Harmon. And this image that we have up here is just for your information and edification of the female reproductive system. So thank you so much. And why don't we go ahead and just do our little poll, Alicia, about how often people are seeing their OBGYNs.
So you're actually going to get a couple of questions, but if you guys just do the first question, we would appreciate that. So let's see. You should have a poll on your screen. You can go ahead and answer. Doctors, no cheating. It just should give you just a couple of seconds there to answer that question. I know I've definitely heard mixed results on this myself, how often you should visit, and what my girlfriend hears and what I hear, and if you're married, and all these kind of things. So so far we're getting all everyone is answering so far every year. So now I feel silly. Oh, I got one person with an every 2 years. Still got a couple more people to answer. We'll give you about 10 more seconds. looks like all of us. So I'm going to go ahead and end that poll. We've got 90% of people are saying to visit every year, and just, well, that leaves 10% saying to visit every 2 years. So we'll just get that off of your screen for a little bit there.
Dr. Harmon, what do you think about that?
Oh, we can't hear you.
You're on mute, Dr. Harmon.
I'm very happy you guys coming in once a year. We're very pleased that that's the practice of most of you here on the panel. Every 2 years, I think, is okay, but surprisingly, we have seen from 1 year to the next some symptoms pop up that patients may have ignored or didn't think it was abnormal, and we pick up certain things. So if you're not seeing your gynecologist, we'd encourage you to at least see your primary care doctor just for your wellness visits, especially since the Pap smears have been spaced out. So some patients are choosing to do that.
Excellent. Thank you so much, Dr. Harmon. All right. Now let's talk about our breast health with Dr. Collins.
Yes, thank you so much. Could you go to the next slide?
Absolutely. And if you'd like, we can let's start with a poll for Dr. Collins about how often you think you should get a mammogram. We'll relaunch that poll. So we'll just move on to the second question, and you guys can let us know how often you think you should get a mammogram. All right.
Dr. Sagunro, the polls are coming in. So far, everyone has said every year.
All right. Great. Dr. Collins, I'll let you take it away so you can demystify this for us.
Perfect. So I'm not sure the age range of the participants in our group, but the picture is referring to a mammogram. If you haven't had the pleasure of experiencing that yet, that's what you have to look forward to. There is, as you can see, there's some positioning requirements, and it can be a little bit of pressure to get the picture we're looking for. So to answer the question, when should we get our mammograms? And for many of the physicians, there's multiple medical groups that provide recommendations. And so we kind of take a look at all of those recommendations and we base our own off of that. For me, I'm a breast surgeon, which means I'm not usually the first line of somebody you're going to see if you have a breast complaint. Usually you'll see your primary care doctor or the obstetric gynecologist, as Dr. Harmon mentioned. But what that means is that they kind of look at these recommendations and go from there. So for me, I'm a very aggressive screener because I know that 1 in 8 women can be diagnosed with breast cancer, which is about a 12% risk for a lifetime risk of a woman. So for me, screening is the best thing that we can do to catch them early and treat breast cancer. So I advocate for aggressive screening. And some of the societies that you'll hear is the American Cancer Society, American College of Obstetrics and Gynecology, the American Medical Association, and all of them have variations of similar recommendations. The most aggressive and the one that I follow is starting at age 40 and going annually for your mammograms. Your physician isn't necessarily wrong if they recommend you waiting to age 45 or 50, but that would be a more relaxed imaging recommendation of one I don't recommend. I recommend starting at age 40. There's about 7% of women who will get diagnosed with breast cancer under the age of 40, and that 7% is enough for me to recommend starting at 40. I don't want to miss anything further than that. If you have a physician whose recommendation doesn't align with what you're looking for, if you prefer to do an annual recommendation schedule, you just have that conversation with them and tell them, I would prefer to have mine annually, and all of that should be covered by insurance. It's never an insurance problem of getting your mammograms annually. The one kind of caveat to when you get your mammogram is if you are someone with a family history of breast cancer, or personal history of breast cancer, or you're what's considered high risk. And to the physicians, high risk is considered when you have a lifetime risk of 20% or more. And we kind of use a calculator to add in the factors that can increase your lifetime risks. Some of those things are if you've had a family history, your age that maybe have some breast biopsies done for benign other issues, different things, and we can calculate a score and get a score for you. Typically, the most common thing to bump you up into a higher risk is having a primary family member who's had breast cancer or ovarian cancer, and that would be in your parents, your siblings, or your children. And if you are what we consider high risk, we would consider adding an MRI to your annual screening mammogram. So you could get an MRI and a mammogram yearly. You always, always, always want to have your mammogram, and the MRI is just a nice addition to that for some increased screening. But the mammogram is what you should always have done no matter what. The other thing that I wanted to mention was family history and why that's important. So there can be some idea that if you don't have any breast cancer in your family, that you are of lower risk, or you don't need to be as concerned if no one in your family has had breast cancer. And unfortunately, that is not a myth that's true. Family breast cancer, we see in about 10 to 20% of breast cancers. So the vast majority are actually not related to inherited family cancers. They're what we consider spontaneous, which is why we advocate all women, not just women who've had family history of breast cancer, get their mammograms at age 40. As we're talking about the family history, some of the genes that you might hear of are BRCA1 and BRCA2. If you have a family history of breast cancer, it's a good thing to talk to your doctor because they can recommend getting a genetics counselor and genetics testing to see if those two, which are the most common related to breast cancer and ovarian cancer, and there are a handful of others that you could be tested for to see if this means that you have a higher lifetime risk. But knowing overall that just because you have breast cancer in your family doesn't necessarily mean you're going to get breast cancer, but you are at a higher risk. You should definitely be doing increased screening, and that the majority of women get breast cancer don't have a family history. So all women, we advocate at least age 40. And then the other point of that is if you do have a family member, parent, sibling, or child less so, but you're going to want to start your screening 10 years before that person in your family had cancer. It's a little less clear for like aunts and great aunts, grandparents, things like that. But for the most part, it's about 10 years younger than the person that you're related to had the breast cancer. And then finally, my last topic that we get a lot in my office is breast pain. So breast pain, to start out saying, is not typically a symptom of cancer. So while it's a nuance and it can be very frustrating and annoying for women, it is the silver lining that it's typically not an indication you have anything bad happening. But it can be pretty frustrating for patients and clinicians because there's really just not a good fix. There's multiple reasons why you could have breast pain. Some of them are not normal, as the question indicates. Something would be like a mastitis, which is an infection of your breast. It might be a benign tumor like a fibroadenoma, which is really not cancerous, but is an abnormal growth of breast tissue that can cause pain. And sometimes it's just having denser breast tissue, denser fibroglandular tissue, and your hormone fluctuations can affect how your breasts swell during your cycles and cause pain. So breast pain, while frustrating, is considered normal, unfortunately, and we pretty much treat it symptomatically, meaning there's not much we need to do. You don't need to have a surgery for this. It's kind of a managing with some Tylenol and things like that. So hope that answers that question.
Thank you so much, Dr. Collins. All right. Any questions so far immediately before we move on? Dr. Akawande?
I wanted to ask a question to you, Dr. Collins. I've kind of heard a rumor that, for women, if they don't have babies or, like have basically never have children, that they have a higher risk of breast cancer. Is that true or false?
That is true. It increases your risk, and we'll go a little bit in detail in a few slides about overall risk factors. But it's a very good point. So your gynecologic history, or when you started having periods, when you went into menopause, how many children and at what age you had them, and if you breastfed, are all things that can influence your breast cancer risk. And it's if you are over the age of 30 and you never had children before then, that's when we start noticing an increase of breast cancer risk related to not having children. And the thought behind how all of that plays a part in breast cancer risk is it's our body's influence of estrogen. So your breast tissue is not fully developed until you've had a child, your first child. So that's a longer time that kind of underdeveloped breasts that are still kind of considered dense because they haven't fully matured are exposed to more estrogen because pregnancy removes your cycle. So that's why the theory is the more children you have would take you out of your menstrual cycle more and would reduce the effects of estrogen on your breast tissue. And that's how we kind of associate pregnancy, breastfeeding, periods to breast cancer risk. Thank you for that question.
Thank
So
you.
if any of the people who are here listening, participating, if you have a question, you can raise your hand through Zoom, or you can type your question right into chat and we can hear it that way. But I do have a question. So as a woman who's recently had a mammogram for the first time, not fun. Why do we have to go every year? I mean, really, is it that important every year? Because it's just not a good time.
Not a great time, and I feel for you. I have yet to experience, but my patients all have a similar reaction. It is not the funnest time in their life.
No.
But what we do know is that while mammograms are very sensitive, meaning they pick up the majority of the breast cancers, there's still quite a few that do go missed by even mammograms. So the reason that we want you to have them yearly is that the soonest that we can, the soonest that we can get a picture of what your breasts look like, we have something to compare to. So the next year, if there's a few more what we call calcifications, which are almost like little grains of salt or scarring of your breast tissue, if those seem to grow, it signifies to our radiologist maybe something is going on. And one of my favorite analogies about mammograms is that breast cancer typically takes anywhere from 3 to 10 years to grow to a point where you would feel it. Our goal is to catch these in the very earliest stage, 0 to 1 stage, to try and treat them. That's when they're very survivable, 95% survival if we catch them very early. One of my trainers said to me that when we have a mammogram, if your cells are, just starting to form a breast cancer, it doesn't mean that it's not there. We just can't see it yet. Nothing's signaling that there's something wrong yet. So it's like an airplane coming in for landing. That airplane is always in the air. It's always coming, but you can't see it at the airport until it's 100 feet from landing, and then it's there. That doesn't mean that it wasn't there 5 seconds ago. You just couldn't see it until it got close enough. So that's one of the reasons that we would advocate. Some of the recommending bodies do start advocating that if you've had 10 years of mammograms and they've been normal with no problems and you're not high risk, they will say, okay, well, you can go out to every other year. And again, that's a discussion you can have with your physician. For me personally, I still recommend annual. It's not fun, but if we're in a 2-year period and something showed up that we could have caught 365 days ago, that's what I would advocate for. If I can treat you earlier, have a smaller surgery, maybe less invasive treatment, you don't need chemotherapy because it's still small enough, that's what I advocate for in general.
Thank you, Dr. Collins. There is a question from Mildred. Mildred, I believe you have your mute on, so if you'll just unmute, Dr. Collins is all yours.
Excuse me.
Mildred, can you hear me okay? Yeah. You're still on.
Can you guys hear me now?
Yes, we can hear you
Oh,
now.
sorry. My question is, have you heard of another type of test called a thermograph? And if you have, what's the difference between that and a mammogram?
The thermograph, I'm not super familiar with. It's not something that we advocate as routine testing.
Mammogram, can you explain to us about how much radiation is it a small amount? So
Radiation in a mammogram?
with the mammogram,
Sure.
how much radiation? Because the thermograph is another option, but I just don't know the difference between the two.
I'll jump in real quick, just a little bit about demography. It's not a commonly used mechanism for detection of breast cancer. What it does is it looks at like the metabolic activity of cells in your body and kind of puts it into like a heat map, based on that activity. Almost similar to how like a PET scan looks at certain activities for certain cancers around our body. But the problem when you're comparing the thermograph to the mammogram, the thermograph is only effective in about 42% of cases. So it's not it's not really a diagnostic tool that we use routinely. It's something that's kind of still more experimental, and it's kind of, when things start out experimental, it's kind of like the hot topic and people are wanting to talk about it and wanting to get it. But in terms of detecting breast cancer for us right now, it's not superior by any means to the mammogram, and its detection rate for breast cancer is only at about 42%, much less than half of what mammogram is. So it's not something that we use by itself, but it is being studied as an adjunct to help maybe localize certain areas of the breast that the cancer might be in addition to mammogram, but not by itself.
Okay, thank you.
You're welcome.
Dr. Segaran. And to answer your question about how much radiation is in a mammogram, it's about, so I'm going to throw out the medical term, it's 0.4 silivert, which basically we relate to is the amount of radiation exposure that you could have walking around doing normal life things in about an 8-week time period. So it's very, very low. And obviously if you have to get repeated mammograms or different things like that, that can increase, but just the once a year screening is a very, very low dose.
Thanks for your question, Mildred. Does anybody else have a question? You're welcome to raise your hand or type it into the chat window.
And again, don't worry, we have lots more time for question and answer as well.
Absolutely.
All right. So let's talk about our pelvis, right? Let's talk about our pelvis while pregnant and while not pregnant. Dr. Akawande, why don't you take it away for us?
Hi, everyone. Okay, so I'm going to talk to you about 3 different questions: why women pee when they laugh, what causes postpartum pelvic pain, and what role physical therapists can play for the pregnant or postpartum woman. This is just a visual of the pelvis anatomy, and in my hand, I have the pelvic floor muscles. I think it's much easier to look at the actual muscles so that I can explain to you exactly what's happening here. So this is basically a network of muscles and nerves, connective tissue that goes from the front of your pelvis, so your pubic bone, which is right there in front, all the way to your coccyx bone, which connects to the sacrum. This big triangular bone is called your sacrum, and at the bottom of your sacrum is the coccyx. And so it extends all the way there and acts like a sling. And I like to call it, it's a sling that's like a trampoline. And trampoline because trampolines move up and down, and your pelvic floors move up and down with your everyday activities. So a lot of things happen through your pelvis. We pee and poop through our pelvis. For women, we have children through our pelvis. And of course, sexual intercourse happens through here. So question number 1, why do women pee when they laugh? Well, the answer is that it really depends. So if we're talking about, and Did you notice that play on words? Some of you got it, maybe not. Uh, um, but so for the pregnant woman, when your belly is growing, basically we're stretching out the tissue of your rectus abdominis or your six-pack ab muscles. Obviously, they're non-existent when you're pregnant, and everything is overstretched. The ligaments are overstretched. And so because there's that huge opening in our bellies, that puts extra pressure going straight down into the pelvic floor. And so, what that does in a moment's notice, when you are doing something like laughing or jumping or sneezing or coughing, that puts a whole lot of pressure on those muscles that may or may not have a lot of support. And so, what happens when you have leakage is that those muscles are not doing its job. On an average day, your muscles hold your internal organs. So, our uterus, our bladder, everything, our intestines is sitting inside of our pelvis. If we're getting leakage, those muscles are not doing the job to hold everything up and in. When it's the postpartum woman, once the baby has gone through the birthing canal, those muscles have taken a beating, literally. And so when the woman's body heals and things are kind of not in the same place, we get weakness of those muscles. Sometimes we get what we call a prolapse of those internal organs, which means those organs go down into the vaginal opening. And so you'll have leakage that comes from that. Postpartum pelvic pain. So a lot of women will have pain after they're pregnant. A lot of people think that it's just pain during pregnancy because you got the low back pain and you see how a woman is typically wobbling. But the reality is that for women who develop issues while they're pregnant, those issues, when they are unaddressed especially, often follow them into the postpartum period. So I like to say that it's a lot of times a continuation of pregnancy-related pain. And then changes in alignment. One of the big ones is vaginal dryness. So if you've been pregnant before, if you've had children, you know that while you're pregnant, there's lots of discharge, there's lots of just, it's all the time you feel like you're leaking. But once you have delivered and had the baby, well, the vaginal area just kind of dries up like the Sahara Desert. And so that dryness can cause lots of friction and pain during sexual intercourse. And then trauma during labor and delivery. If you tear the tissue between the vagina and the rectum, this tissue right here is called the perineum, and that's what when they tell you that you tore, this is the area that they're talking about, that muscle there tore. So if there's any kind of trauma to the pelvis during labor and delivery, if they have to use forceps or anything like that, you're most likely going to have some type of pain. So then bears the question of what role does physical therapy play in the pregnant and postpartum woman? Well, for the pregnant woman, there's a multitude of things. Most of the referrals we get from like the OB sector would be for managing pain. So when a woman has debilitating pain, she can't get out of bed or can't do her daily activities, it's really taken her away from the life she knows, we'll get a referral for that. But I like to say that for physical therapy, I feel every woman should have a physical therapist because our job is to empower women to know their bodies and to do the best with what's there and to understand, because if you don't know what's there, you can't really work with it and understand how to make life better. So we teach women strategies for labor and delivery, things like how to position yourself when you're laboring. If you have a history of pain when you're standing on one leg, how to labor on all fours, or how to labor in other positions that will not further debilitate you down the line. Reducing postpartum complications. So we know what's coming after you've had the delivery. We can teach you things to kind of ease you into going back to life after you've had the baby, because I'm sure you've seen the research. If you're a mom before, women have once you're pregnant, you have checkups every month and towards the end every week, and then once you've had that baby, you have your 1 6-week checkup, and that's it for you, and then it's all about the baby. But we teach you how to manage life as a postpartum mom, how you're going to carry your baby around the house, all those kinds of things. Talk about toileting habits, because there's a lot of pressure, like I said, weighing on your pelvic floor as your belly grows. So we teach you strategies to toilet and reduce things like UTIs. Safe exercising for pregnant women. I know you see on the news or oftentimes in the media where women are, running marathons at full term. That's not for everybody. If you're not a runner before, don't try to do stuff like that. And a physical therapist who knows your full history help you understand what's safe to do and what's safe not to do. So for the postpartum woman, the things that physical therapy does is for the woman who's had a cesarean section, we teach her how to move that scar and reduce scar tissue sensitivity and pain. A lot of times women will have decreased sensation all over the abdomen because of that scar formation. So we teach them how to move that scar around and kind of reduce that pain that comes with moving and having a major surgery. We prevent future problems. I think that's the biggest thing, is because we understand how the muscles are working in your body. And so we kind of help you understand how you have to move differently, how you can't do a lot of the same exercises in the beginning until your body is healed. We help you stop leaking urine. It's commonly known among mom groups that, when you take your kids to like a jump place, moms just don't get on those kinds of things. But you should be able to enjoy whatever it is you'd like to do, and we help you do those things. Improving painful sex. This is a big one because Dr. Harmon talked earlier about the tolerance of the pelvic exam at the OBGYN office. And for women who have a really difficult time tolerating that exam, we work through the pain of those issues to help women tolerate those exams. And then improving toileting issues that pop up sometimes in the postpartum period. And most importantly, returning to exercise safely, because even though in our culture and our society, women aren't generally given enough time for their bodies to heal, and we have this culture of bouncing back. It's important for women to know when it's safe to do certain exercise and to do that well. So that's my piece.
Thank you so much, Dr. Akinwande. Alicia, can we launch that last poll question, please?
Got it. All right, if you'll scroll all the way to the bottom of your 3 questions there, this is a very interesting question. What kind of specialist would you see if you have stress incontinence or pee when you laugh? And this is a multiple choice question, so if you've got more than one answer you want to give, go for it. This was definitely a something I had no idea about. So while you guys are answering, I have a question for you. Doctor, I'm just going to call you Dr. A because I don't want to mess that up. So after I had a baby, which is a while ago, my doctor gave me an exercise called Kegels. And my friend recently had a baby and she had no idea what I was talking about. So is that something that's commonly taught? Did I just get lucky? Can you address that? And the poll, we've got a couple more people still answering the poll.
So great question. I think it just kind of depends on who you go to. I think it is more common these days that a doctor will tell their patients in the postpartum period, do your Kegels. However, I will say that can be not the best information. The reason why I say that is because if you're carrying tension in your pelvic floor, then the answer is not to do more Kegels. The answer is first, because yes. So let me make a real life example for you. So if I have my arm kind of stuck like this, right?
Yep.
And you tell me to flex my muscle, I can't really go much further than the way it looks, right? In order for me to really get a stronger flex of this muscle, I need to first stretch the muscle totally in the opposite direction.
Okay.
And then I can really get the function of it that I need to get. And so I see a lot of women who, they've got a strong contraction, but the issue is that they need to learn how to relax their pelvic floor to stop that pain.
That makes sense. I just remember being very grateful to have learned that activity. So
yes, thank you for that question.
So we've got our poll results in. It looks like 88% people have said a pelvic health physical therapist is the person you should see. A couple of people said the OBGYN and a couple of the urologists. So it looks like we have well-educated attendees. I would have put the OBGYN. So good job, ladies.
Excellent, truly excellent. Now, Dr. Akawande, can you do me a favor and just tell us a little bit more about your extra training in pelvic health? I just think it's important for people to understand this. And as a surgeon myself, it wasn't until when you really explained it to me that I understood. So I think it's important for people to understand the extra training and, basically specialty training that you do in pelvic health to make sure that they understand that really you are able to help them with their pelvic health in adjunct to their OBGYN. It's kind of a team approach. So can you just talk about that a little bit?
Absolutely. Great question. And so I think you make a great point. Our training first of all, to be a physical therapist, it's a doctoral degree, and you go through that after you have a bachelor's or a master's, whatever route you choose. But that doctoral program is 3 years. So after that program, in order for me to specialize in the pelvic health, pelvic floor, it's hands-on training, and I think it was about 24 hours of training. And we have a unique training in that whatever I'm doing to a patient, I've had done to myself as well. So if I'm doing a manual technique or talking a patient through a situation, even if I don't have those symptoms, as a part of my training, I've had to manually experience and demonstrate that. So the training is a combination of hands-on, written testing, and then like a personal case study times two. So great question, Doctor.
All right. Thank you so much, Dr. Akawande. So I have a couple questions for the panel, but what I was going to do in the interest of time is I'm going to go ahead and ask our panelists to just briefly answer these, and then we'll just go right into our open question and answer for our audience, okay? So the first question I have is for Dr. Matura Harmon, and I would just like for you to talk a little bit about what some of the concerns are in terms of morbidity and mortality associated with childbearing in the African American community. This seems to be something that's being talked more and more about in the medical community and in the news. So I'd just like to hear what you have to say about it and what your experience is.
I think currently we're in a climate of people just recognizing the systemic injustices that's going on, and the CDC recently published a research that African American women are 2 to 6 times more likely to die from complications of pregnancy, depending on where they live, whether it be socioeconomic status or education. And the primary or leading causes of deaths amongst the African American women are preventable. And so it's very alarming that in a first world country that we're seeing such high death rates amongst just one race, I should say. So we see postpartum hemorrhages, pregnancy-induced hypertension, and embolic diseases such as pulmonary embolism or stroke. So those are the leading causes of death. And there haven't been any like pinpoint causes or factors. We think it's more social things such as just the quality of prenatal and postpartum care. There's lifestyle factors, that are prevalent in the African American community. There's socioeconomic. So some women are just not very informed or don't have the finances to get appropriate care. And then there's also health deserts within the African American community. So as we're seeking prenatal care, some women may not know that they're pregnant, so they don't seek out care early enough, or they just don't have an opportunity to get to a quality clinician or clinic to provide them the appropriate care. And so there's a lot of things that are early on that are noticed and screened for and monitored throughout pregnancy that may be done too late. There's other things such as just conditions like diabetes, pre-existing hypertension, fibroid disease that can increase the risk of postpartum hemorrhage. And then there's also now being looked at as how with institutionalized or institutional racism, how just because of being an African American woman, that there is different standard of care and how someone may treat you because you are African American. So the prevalence or the increased risk is something that has always been there, but I think now with the recent study and just looking at social injustices in our country, it's being a lot more recognized, and there's many more initiatives and just education around this subject to try to find more information as to why this is happening and to decrease that risk.
Wow, excellent. Thank you so much, Dr. Harmon. Dr. Collins, I was wondering if you can talk to us just a little bit about some of the risk factors that are associated with breast cancer, particularly those things that we can change ourselves or modify.
Sure. So we touched on it a little bit before, but I'll try and focus on ones that we consider modifiable, which means things that you can influence in your life that could affect positively or negatively your risk. To kind of give a brief overview, some of the things that you can't control would be being a woman automatically increases your risk for breast cancer. Men can get breast cancer, but women are the majority. As you age, your age is an increased risk for breast cancer because it increases as you age. So the older you are, the more likely you are to get breast cancer. Another thing you can't control is if somebody in your family had it. You can't control if you already had cancer, but it does increase your risk for another cancer. Another thing you can't control is if you've had another disease that required you to have radiation to your chest. Usually those are like a lymphoma or a thymus problem. Your race or ethnicity. So white Caucasian women are typically the ones who are diagnosed more with breast cancer than Asian women or Black women. But Black women typically get more aggressive types of cancer, and their survival is less. Your gynecologic history, meaning when you had your first period and when you entered menopause, again, nothing that you can really do about that. It's the estrogen influence in your body. And then one that's relatively new that we are focusing on is breast anatomy. So having what's called dense breast tissue means that your fibroglandular tissue, which is the component of your breast that creates the structure of the breast, which creates the milk and which lets the milk down when you're breastfeeding, if that's a very dense tissue, that can increase your risk of cancer. And it's not necessarily because you have that tissue, it's because it's harder to see through that tissue that it delays your diagnosis. And then things that you can do something about. So we talked about pregnancies. I don't know that you would base your pregnancy planning on decreasing your breast cancer risk, but to keep in your mind that if you have a child under the age of 30, that decreases your risk. The more children you have, the more pregnancies you have, decreases your risk. If you elect to breastfeed, typically we say it starts showing positive decrease in your risk of breast cancer after you breastfeed for a year. So in the United States, typically women don't usually breastfeed for a year, but that's where we start seeing the benefits of it. And then obviously that's a choice, but again, I don't know that you would make that in relation to your breast cancer risk. It's kind of what fits for you and baby. And then another modifiable thing is if you have reached the age of menopause and you're having significant symptoms, sometimes hormone replacements are recommended to you. Just bearing in mind that if you use a combination of hormone replacements, they can increase your breast cancer risk for up to 75% increase. Usually when you come off of those medications, it takes about 2 years, but you will go back to the normal risk that you had when you were not taking them. But just to be aware that when you're on them, the exposure can increase your risk because of the estrogen influence. Another thing that we have, and these are the ones I'd really like to hammer home on, are our body mass index, which is related to weight. We typically see it in women who are postmenopausal, they've had their last period, that if they are over a BMI of 25%, that can increase their risk of breast cancer. Weight and breast cancer risk is a complex topic. So there are studies that show younger people who are overweight, it's protective. Some studies show that once you've hit menopause and you're overweight, it increases your risk. So the takeaway that we know is to keep your body mass index well controlled, eating healthy foods, a well balanced diet. There's no diet that causes breast cancer, there's no diet that will treat breast cancer. Along those lines, exercising. When we exercise, we know that that means you're typically an overall healthy person. So we recommend having 4 to 7 hours a week of moderate intensity exercise, which is pretty much like a 30 to 45-minute walk every day. The other one is alcohol. So it's been studied compared to women who drink 3 drinks a week compared to women who drink none. There's a 15% higher lifetime risk of breast cancer in those that drink the 3 drinks per week. And there have been studies that show that each additional drink per day can increase your risk overall by 10%. So we really recommend for women to limit their alcohol consumption, even as going back as the age of a teenager, which we don't really discuss because we don't think about breast cancer in teenagers, but the overall risk of alcohol consumption can add to your breast cancer risk. So we define a drink as 12 ounces of beer, 5 ounces of wine, and 1.5 ounces of liquor. So we would limit that to 3 a week, is what we would say. And I think those are all the ones that I really wanted to. Oh, smoking. Obviously, smoking increases your risks in general for cancers. And there is some studies that show that it influences your hormones as well. So don't smoke.
Excellent. Thank you so much, Dr. Collins. I was going to go ahead and open it up to our Q&A, and then we'll come back and have Dr. Akinwande talk to us a little about the Mommy Makeover once we answer some more questions. Are there any burning questions, any questions we want to ask, any topics we want to discuss, ladies and or gentlemen, on our talk today? Again, if you have a question that you want to ask in confidence, you're more than welcome to put it in the chat, in the direct message chat to the Do Influence, and we will ask it confidentially. I'll go ahead and ask a question of really of all the panelists. What is the most common myth or fallacy would you say there is in women's healthcare? So in each of your specialties, what would you say is like the one thing that you wish women would stop doing, that you think that they're the most misinformed about? Set us straight. Why don't we start with you, Dr. Akinwande?
Oh, I think that I would say don't wait. A lot of women who come to me um, only arrive after they've waited for a long time. Just to give you a couple of fun facts, the average woman who has something like stress incontinence waits anywhere from an average of 1 to 5 years before she tells somebody that she needs help. Your average pelvic prolapse patient, so someone who has like a descent of their internal organs, 50% of those women are asymptomatic. That means they don't know at all until suddenly everything is falling out and falling apart. And I'll liken that to the airplane analogy that Dr. Collins gave earlier. It's always moving. You just can't see it or feel it, but I can. So there's a difference there is when you come to me and I do that examination, I can tell you whether your organs are moving with certain activities and get you the help that you need early to reverse those symptoms. But if you wait, then you'll never know. And so I have a lot of women who come to me not even knowing who I am, just like, hey, my doctor said this is my only option before I have surgery or after surgery. And it's like, I just wish women knew not to wait. If you plan on having a child, if you plan on having multiple children, find a physical therapist that specializes on the pelvic floor in your area. You can search that through the American Physical Therapy Association website. And there aren't many of us out there, but we're out there.
I would say for me, the biggest fallacy is that every pelvic exam is a pap smear. I think a lot of people or women will go into the emergency department or they'll go to their general practitioner when we're looking for maybe an STD or we're looking for just some type of what's the cause of your discharge, and they assume, and maybe it's just like nomenclature, the name, a pelvic exam is not a pap smear. Pap smear is specifically for cervical cancer screening. So I think that's the biggest um, thing that I find in my practice. A patient will come in and we'll ask, when was your last pap smear? And they'll be like, oh, I went to the ER because I had this pain or this discharge or whatever. And that's when I had my pap smear. So there's a lot of education around that. But I think for me, from my perspective, that's probably one of the bigger things.
And for breast health, I would say we kind of touched on it a little bit. But what I see is a lot of people don't consider that if they don't have breast cancer in their family, that their risk of breast cancer can't be that great. So sometimes women have a tendency to be the caretakers in their family, and they kind of tend to put themselves last. And one of the myths I wish I could dispel for them is that your health is the most important. You can't take care of those around you if you yourself aren't taking care of yourself. So I really wish I could get women to put themselves first a lot of the times, focus on getting their mammograms and their screening, things that they need to do elsewhere too, their colonoscopies, their pap smears, things like that. But taking serious consideration that it's not just if you still have it in your family, that everyone has a lifetime risk of breast cancer to be aware of.
Thank you so much, doctors. I really, really appreciate that. That's such an important thing to make sure that we are getting the correct information and that we're not kind of doing our Dr. Google thing, right? That happens a lot, but also sometimes there's just so much misinformation out there. So it's really important for us to get that direct information from you all. So thank you for sharing that. Um, I would love for you, Dr. Akinwande, to tell us a little bit more about the Mommy Makeover. And again, anytime anyone has a question, please put your hand up or just jump right in and start asking questions. Really, this is an open forum for you to ask anything that you would like, and we will do our best to answer.
Okay, so the mommy makeover is basically your suburban woman's dream. After a woman has had all of her children, she just goes into surgery to get basically a breast lift, a tummy tuck, and liposuction and whatever else she wants to do on her face, neck, whatever. So it's just a way to pretty much kind of erase the effects of having a baby. And what women don't realize is, okay, you can put all the muscles back together, but if you don't fix the underlying issue, just like everything else, it will still eventually fall apart. And so it's beneficial if you like aesthetics, and if you don't like the way you look, hey, go for it. But I would just caution you to not just aesthetically put yourself together, but also make sure you understand what's going on inside of your pelvis and inside of your core so that you rebuild from the ground up. And so the alternative to something like a tummy tuck or a mommy makeover is pelvic floor physical therapy. The reason why I say that is because most women go into this surgery after carrying that belly that looks like you're still 4 or 5 months pregnant. And yeah, it's off putting. But what it is, it's weakness of your core muscles. And what that condition is called is diastasis rectus abdominis. Essentially, what's happened is the ligaments and the muscle is like very relaxed and loose. And so we teach you how to rebuild your core from basically from the ground up. So from the bottom of the pelvis all the way to the top of your rib cage, how to reform and reshape those muscles, how to do exercises differently. And you may not get the space to close up entirely, but you can have a functional core that looks good in pictures. Now, again, as far as doing the breast lift and all, there's not much I can help you with there, because the more you breastfeed, the saggier they're going to be. And the more kids you have, the more they're going to grow. So, life has its consequences. But we do have exercises that you can do to lift those breast tissue muscles. So there are options. And if you want to do it a more natural way, a pelvic floor physical therapist can show you exactly that.
Thank you, doctor. We do have one question from Sophia. So Sophia, if you want to unmute yourself and feel free to ask away.
Hi, ladies. Thank you, first of all, for putting on this forum. I greatly appreciate it. You guys are doing a great job. Just a couple of random questions. First for Dr. Akawande. In terms of a woman, myself, I'm of childbearing age, but I don't have any children, and probably will not for several years. Just curious as to what can we do to strengthen? I mean, do you advise that a woman go ahead and see a physical therapist specifically with your training, even if you're not looking to get pregnant anytime soon? Or are there certain exercise things we need to be mindful of that you're just doing in preparation for the future? Things like that, like exercises or anything?
I think that's a great question. You know what? At your baseline, it would be good to know, do you have a diastasis? Because some people just naturally have one. And so if you naturally have one, the best thing you can do before a baby comes into your body is close that space up. It's much easier to do having not had the effects of pregnancy, labor, and delivery. And then secondly, the second part of that question is, do you want to see a physical therapist before you have a child? Absolutely. Just like if you're going to run a marathon, and you're going to train for it, you're going to go through, the best routine you can find. You're going to do everything to get, as good of whatever it takes for you to run that race well. And so I consider myself to be on that team for women. So yes, rehabbing your core and your pelvic floor. And also I think it'd be good to see a physical therapist, because I have seen women who've never had children before but already have a level of prolapse. And so if you go into pregnancy knowing you have prolapse, you can do things to reverse that before it even moves any further. So yeah, absolutely.
Okay, thank you. And then I have a one quick question for Dr. Harmon. So if somebody was so looking for a new OB. I've gone to the same OB probably since I was like 18 and really didn't really think much of it. But in terms of like a future and having children, and then like you talked about earlier about maternal mortality rates in African American women, are there certain questions that or dialogue you can have with your OB just to kind of talk about these certain issues, or maybe like, I don't want to say interview, but maybe like a specific like birthing plan, or just your idea of what you're wanting out of your women's health physician, or what
Yeah.
are appropriate questions to kind of talk to them to bring up whatever concerns you have regarding maybe some of those topics.
hmm I feel that just like we ask questions of patients, that patients should have the liberty to ask questions of their physician. In terms of seeking a doctor for your pregnancy, we do have preconception counseling, and so that is a great opportunity to meet with a doctor and talk about your birthing plan. And I've had a patient just straight up ask me, she says, "What are you doing to affect the changes in the morbidity and mortality of African American women?" Like, that was her question. And so
Because
I,
I didn't know if that's appropriate, because that would be a question I would like to ask.
yes, that is an absolute great question to ask your doctor. And there's some doctors that can be off-putting to, but if the doctor has that type of response, then that's probably not the doctor for you, because we are in the practice of educating our patients and giving you the best care possible. And the more informed you are as a patient, I think the better your care will be, because that's a doctor that's going to listen to you whenever you have a concern or you have something that you feel is not right. I mean, I think in a lot of these cases where we talk about the morbidity or the high incidence of our patients dying, it's because their doctor maybe didn't listen well, or they kind of loop them in a bunch where, this is what happens with most of our patients. And it really is We have to treat each patient individually. We hear about these cases in the news, like Serena Williams, and just recently this lady that died of preeclampsia. And again, these cases are preventable. We wonder, had their doctor listened, would their outcomes been a little bit different, or would they, if they paid closer attention, would their outcomes be different? So I think in searching, number one, preconceptual counseling is important. Developing a birth plan with your doctor is important, and just feeling comfortable with your doctor. And we want to feel comfortable with our patients as well. That gives better outcomes for your whole pregnancy, including your labor and delivery.
Okay. Thank
Can
you so much.
Thank you,
I,
Dr. Harmon.
Hmm.
can I add to that also that I feel like if you know you're going to go through this whole pregnancy process, I also feel it's important for women to have an advocate with them, because when you're laboring and going through the delivery process, you don't have the energy, the wherewithal always to speak up for yourself. So it's really important to go with an advocate. Even if you tell your doctor your plans and they agree with you and such, if things start to go left, someone needs to be able to speak up for you when you can't speak for yourself. So always have an advocate.
Thank you, Dr. Akinwande and Dr. Harmon. Seriously, those are really important topics. I do have a question. Dr. Akinwande, one of our members that's participating tonight would like to know, the pelvic physical therapy, is it something that's covered under insurance? And how can someone go about getting it, right? So how do they ask their doctor? Do they need to do some other steps? How can they basically
Great
get it?
question. So the simple answer to that question is that it really depends on where you live. Um, most insurances will cover it, but sometimes there are hoops or hurdles that you have to jump through. Where I am, a woman can just come to me straight on. I'm in Texas, and so no, you don't need a referral, but you do have to have a doctor sign off on the care plan. So what you might do is find the physical therapist. I mean, like I said, it depends on where you are, but here someone could find me and then talk to their OB about it, and their OB could either write them a script to come and see me or sign off on the care plan once we get started. But yeah, most insurances are willing to cover it. They just need sometimes they need to have the doctor's referral for it. Um, and in some states, they have what we call direct access, and you can just go into a clinic and your insurance covers, because it's the same thing as outpatient physical therapy. It's covered under the same thing. So sometimes insurances will cover up to 20 visits a year, 30 visits a year. It just kind of depends on what your insurance is. So I would recommend you call your insurance first and find out what the regulations are and go from there.
Okay, thank you. So calling the insurance first then. So that's some good advice. Thank you. Um, any other questions? At any time, if you do need to leave, feel free. I know that this event is scheduled from 8 to 8:15, but we're still here. We're still answering questions. Our panelists are available as well to continue answering questions. And this, again, will be recorded, so you will be able to rewatch this and kind of continue to learn from the great advice that we've gotten this evening. But yeah, we're still open for questions from anyone.
I was just wondering, typically, how long does it take for the physical therapy? Is it like something that's 3 to 6 months, or 6 months to a year, or is it like something long term for
That's
the
a great
physical?
question. It really depends on the severity of your case. Like each individual patient is going to be different. If you're coming out of having your first child and you've not had any problems before, and you maybe have an acute case of symptoms now, it could be that you could be done in 3 or 4 visits. But if you've had like a long-standing issue or chronic issue that you've dealt with for years, don't expect that it's going to be done in 2 months. Sometimes that does take up to 6 months. It just really depends.
Thank you. Great questions.
I have a question for Dr. Harmon. Dr. Harmon, I was wondering, um, for patients who either don't have not had children or those who do, what is the best type of birth control? I came in a little bit late to the class, but what's the best kind of birth control to recommend to patients that might be an easier transition on and off without a delay period for conception, whether you're between kids or prior to having kids? Like there was a young lady who asked earlier that, when the time gets closer, what can one take that's most safest or most advised with the least hormones to transition?
So, we have just the regular pills. I think that's a very easy form of contraception that's, I would say, relatively easily to turn on and turn off in terms of your compliance. That's what's most important. I think some women are under the misnomer that if I take my pill, then I won't get pregnant, such like the morning after pill or the plan B. The problem with the birth control pills that you have to take it at least for about 2 weeks around the same time every day for it to be effective. So usually we encourage patients to use backup protection such as condoms once they start it. So if you are someone who is interested or nearing conception, wanting to get pregnant, I would say the pills would be the easiest method of contraception to use. If compliance may be difficult for you, the next best thing may be the Nuva ring. That is a like a rubber that is placed into the vagina that you wear for 3 weeks at a time, and then you remove it, you have your menses, and then you replace it. So compliance is a little bit easier with that. I think those two are probably the shorter termed methods of contraception with return to fertility. Um, Once we go beyond that, we're looking at LARCs, or long acting reversible contraception, which would be a little bit harder in terms of the hormonal effects to return to fertility. So that would be the Depo shot, which um, works as contraception for about a 3-month period, but it does affect how your ovaries respond. So even though the hormones for about 3 months, sometimes people can have difficulty resuming their regular cycle for another 3 months potentially. And everybody's body is different. So you could be someone who, you're due for your shot in a week, and then you miss it a week or two, and then you get pregnant very quickly. But that's one where I see patients having a little bit of a harder time resuming to fertility. If we're doing the devices like the IUDs, there's a 3-year, 5-year, and 10-year method. Those are quickly reversible. So if you remove them, you can get pregnant pretty quickly, especially with the Paragard since it's non-hormonal. So that is an option as well, but not for someone who's hoping to get pregnant within about 3 to 6 months, because these devices are recommended for 3, 5, or 10 years. There's also a device called the Nexplanon. It's inserted into the arm. It's called a subdermal implant. That one we like to use for our young women, just because it secretes the hormone and you don't have to think about anything like taking a pill or placing a device in the vagina. And for patients who may not have had children yet, placing an IUD can be quite painful. And so I think that device works really good, but it's a long term, so 3 years. And patients who use that really have good return to fertility with that as well. So to answer your question, if you are someone who is interested in having a child soon, but not quite yet, maybe in the next 3 to 6 months, I would recommend the pills. And if you may have an issue with compliance or remembering to take the pill every day, and maybe you're comfortable with using tampons or inserting, or don't have any issue with inserting something into the vagina, the NuvaRing is great. You don't have to remove it when you're sexually active. It's not something that you necessarily feel, and you can keep. And the guys tend to not feel it either. And if you do want to remove it, you can remove it during intercourse and just place it right back in within an hour after you've had sex.
Thank you, Dr.
Thank you.
Harmon.
You're welcome.
I do have a question for Dr. Collins from one of our audience members. I'm going to go ahead and read it. The audience member has an aunt who had a double mastectomy and has a younger sister who had one just a few weeks ago. Does that increase her chances of getting breast cancer, even though 3 of her sisters have negative BRCA tests? And also, are there other tests that she should be doing in between the mammogram? She is worried.
Can you clarify? So you said an aunt, and then is it the aunt's daughter or the person who's asking's daughter?
Her younger
Younger sister.
Oh, okay. You can go ahead and ask it directly. No, please go ahead.
It's my father's sister and my sister. My
Yeah,
younger sister.
sure. So there are other genetic reasons that you could have breast cancer besides just the BRCA1 and 2. If your sister was tested, a good question to ask her would be what genes she was tested for. Sometimes they only do the BRCA1 and 2, and other times they'll include a panel, which is things like CHEK2 or PALB2. So to find out if it was a full screening or just for the BRCA1 and 2. Because your sister did have it, and there is in your family of your aunt, it may increase your risk, but it might not reach you to the 20%. But it's something that your family doctor or whomever orders you mammograms should know. And then, is your sister younger or older than you?
Younger.
She's younger. So because she's your primary relative, if you have not started screening, I would recommend that you start now.
By screening, do you mean having these tests done, or?
Correct, like a mammogram. We typically say 10 years younger than the primary relative, and since she's younger than you, it would be a good time for you to start then.
Okay, thank you.
You're welcome.
So as a primary care provider, I would say, you asked about testing. Generally, in these instances, we would do, try to screen for what your risks potentially are. And then a lot of times we'll send you to a geneticist as well. So some of the tests that she was mentioning, like the BRCA1 and 2 and so on, whenever we send you to a geneticist, they will actually ask a lot of questions about your family history and so on. And then they can send you for additional testing beyond just the BRCA1 and 2. And they can kind of give you what your potential risks are as well for developing breast cancer.
Just to kind of parlay off of that, so nationwide, different recommendations for whom qualifies for genetic testing and screening can be in effect. So it's not that it's unavailable to you, but sometimes if you aren't the primary person affected, I feel like your family will probably get you qualified, but should the case arise that you're not, out-of-pocket testing has become very much more affordable. Before it was like $2,000 to get yourself tested, and now the cost is down to about $150. So even if they tell you that you're not a candidate, you can still request to have it done. You just might have to pay out of pocket. So just kind of keep that in the back of your mind too.
Okay, thank you.
You're welcome.
And another thing I wanted to chime in there along the breast health train is, don't forget the power of community resources. The genetic testing is something that's not as easily obtained in terms of a community resource, but there are more and more grants and more programs out there now that are really trying to get women tested. Breast cancer is one of those disease processes that is very common, right? In your lifetime, right? In American woman's lifetime, she has a 12.5, about 13% chance of developing breast cancer, about 1 in 8 women, right? So there's so much money and so many resources that are going towards breast cancer research. And we have made a lot of headway from where we were 5 years ago, 10 years ago, 20 years ago, heck, where we were even 1 year ago. Now, with that said, there are a lot of community programs that do help with, free screenings, like free mammograms. And then there are more and more programs that are coming out with helping with identifying those people, like Dr. Collins said, that would be a candidate for genetic testing. And there are some programs that are offering it. Again, I don't want to get your hopes up in terms of it being specific in your location, but depending on your location, depending on the program, and depending on the community resources, there are a lot of avenues to get some assistance with this. And the next question someone might ask is, well, how do I find those places? So I think the best place to start with is your community health department. So not necessarily your doctor's office. Your doctor's office or the hospital may not necessarily know those, but your community health department. So for example, I'm in Connecticut. I'm near Bridgeport. So I would start with the Bridgeport Community Health Center or Community Health Department, and then go from there. Usually the city health department are very versed in those community resources that are available within that area. And then they can refer you to maybe a local hospital that is partnered with them that is also able to take part in those resources. So that's just something I wanted to throw out there, that breast cancer is an unfortunate disease, but the fortunate part about it is there's a lot of money going into breast cancer research and also community resources for it. The second thing that I just wanted to ask to Dr. Collins for the audience is, we talked about mammograms and ultrasounds. Now, why do some women have to really get an ultrasound after a mammogram? Can you tell us how this has something to do with the dense breast situation, and why some women, particular age groups and things, may be better off with the mammogram in addition to their ultrasound? I'm sorry, I said that backwards. Their ultrasound in addition to their mammogram.
Sure. So we'll start with, what is the ultrasound? The ultrasound's an alternative method that we use for imaging, and it's very similar to an ultrasound that you would have for pregnancy, or pelvic conditions that you might be getting a pelvic ultrasound for. Basically, it's a wand. It emits sound waves, and we put that over the tissue of the breast, and they scan the entire breast, and it can give us different appearances of different breast tissue and maybe pathology, or things like cysts or masses or cancers. The first kind of indication of why someone might recommend an ultrasound outside of a mammogram is younger women. So women under the age of 35 who are of average risk for breast cancer and maybe are coming in for a complaint of they felt something, or abnormal nipple discharge, things like that. Because we know their breast tissue is pretty dense and hard to see through, mammograms are not what we consider first line for them because their breast tissue is so dense. So the ultrasound would actually be the first thing that we recommend for young people when we're looking for, could something be going on in the breast. Specifically related to your question, Dr. Sebenrow, is a mammogram. When would you get an ultrasound in addition to the mammogram? So we look at the mammograms and we see, are there any concerning findings? And they give levels and ratings to that, so the doctors can all be on the same page. This is called the BI-RADS level. So I know that my patient, if it's a BI-RAD 4, that means something to me, and it means the same thing to the other physician. It's all the same speak. And what those different levels mean is how much more we need to investigate the findings from the mammogram. So if I have a rating that tells me it's highly suspicious for a cancer, that would be my next step to say, we need some more information typically the ultrasound provides a different view of how we can see a similar problem. So again, it's just giving us more information on a potential disease or mass or pathology going on in the breast. The benefit of the ultrasound is there's no radiation with it. It's sound waves. It's non-invasive, meaning you really don't feel anything besides some cold jelly. Sometimes it's warmed. We try and make it warm, so that can be helpful. But sometimes the cold jelly can be a little bit stunning for patients. But there's really no adverse effects of having the ultrasound added. And then if they do find something, sometimes they will recommend a biopsy, and they might be able to localize the issue or the problem or concern with the ultrasound, which is considered a less invasive thing than needing to localize the issue with like a mammogram. So it's just another alternative way to look at the breast tissue or look at any issues.
Excellent. Thank you so much, Dr. Collins.
Okay.
All right. Any other questions from the audience? We're going to wrap it up. Again, feel free to ask, put your hand up, ask directly, or write into the chat. While we're waiting to see if there are any other questions, I just want to let everyone know that this is an event brought to you by the Do Influence. Again, it's an online educational platform that you can visit at www.thedoinfluence.com, and that's do as in DUE. I did put the website in the chat. I'll rewrite it again for everyone as well. Please follow us on social media. We're on Facebook, Instagram, Twitter, and LinkedIn. So please definitely check us out. We have a lot of educational opportunities for students of all ages. The big thing about our platform is we try and educate students about different careers and professions. And really, we are an online network where we get students in touch with other students, but also with other professionals and mentors, like my esteemed colleagues here today, Dr. Akinwande, Dr. Collins, and Dr. Harmon. All three of them are part of the Do Influence. So if you do want to get in contact with them, you can definitely get in contact with them through emailing us at the Do Influence, and we'll get you in contact with them directly as well. Please join us for our webinar next month. Next month, we are going to have another educational webinar. It's going to be on December 16th at 4 p.m. We have educational webinars every month. Our health panels will be every 3 to 6 months. So, of course, we did a women's health panel today. We will be doing a men's health panel in the spring. So tune in for that as well. Next month, Miss Nicole Crooks will be talking to us about the nursing profession, both for nursing students and for students that are, or nurses that are already in the profession trying to advance to advanced practice nursing degrees as well. So definitely tune in for that. If you know any students that are interested in nursing, that are in middle school, high school, college, in nursing school already, please definitely have them tune in. All of our webinars are free. We put a lot of work into it and just really want to make a difference in some way, shape, or form. So I really appreciate you all tuning in tonight. And I would really love for you guys to follow us on social media and stay in touch with us and be a part of our community. All right. Any other questions? I think I saw your hand, Mildred. Did you have a question?
I just was looking for the website.
Yep, I'll type it in again.
Thank you.
You're welcome. And definitely follow us on social media. We have a lot of fun things. At least I think they're fun. I don't know, I hope they're fun. We have games, prizes, and we add things every month, and it's a lot of fun. We are going to be starting some monthly trivia next month. I'm giving y'all getting the inside scoop the first time. We're going to start with monthly Jeopardy. Okay, so next month it's going to be an online Jeopardy game, and it's going to be superhero categories. Why? Because I'm a nerd. All right. Are there any other questions? If not, we'll go ahead and wrap it up. And I just, again, really appreciate everyone for joining us tonight, being participant in our lively discussion. And again, if you have even questions after this event, feel free to email us. Again, you can contact us at the Do Influence at gmail.com, as well as through our website. Again, we have a lot of great free resources for you, so use them so we can, have you be part of our community. And also, when you go to the website, you can sign up for our newsletter, and that way you'll get a monthly newsletter to know all of our upcoming events and be in the know. Yeah, come and honestly, the first start is just even following us on social media and going to our website and subscribing, and basically you'll be able to get all of our updates all the time. And we have a really great team. Alicia is part of that team of wonderful people who help me on a regular basis, on a daily basis, and we really put our heart into it. So let us help you. That's what we want to do.
Thank you.
Yeah, absolutely. To our panelists, Dr. Collins, Dr. Akinwande, and Dr. Harmon, not only are you guys my colleagues, you are my dear friends, and I really appreciate you guys for being on today. I just, always am in awe being in your midst, and I think that you are some awesome, awesome, awesome physicians, and I just am so glad to be a colleague and a friend, so I sincerely thank all of you.
Thank you, and thanks for giving us the platform to speak out and be a part of this.
Absolutely. All right, everyone. If there are no other questions, we'll say bye and have a great night. And again, please follow us, contact us. We would love to reach out to you.
Bye, everyone.
Bye.